Well, hello, and thanks for joining. Let's do a comprehensive review of the chapters that you have discussed currently in your pharma course. And hopefully this will be a very, well, comprehensive, but yet almost general review. And then you can expect some further support as well. Please check your Canvas announcements for further guidance. Okay, so let's talk about this. Let's talk about chapters 1 through 5. Chapter 1 talks about general principles of pharmacology. So what I hope to provide is a higher level, I shouldn't say higher level, but an overview. Okay. So foundations of nursing as far as pharmacology goes. So what is pharmacology, right? These chapters are going to lay the groundwork for safe medication therapy. Basically, chapter 1 introduces general pharmacology principles such as pharmacokinetics. Think about the word pharma or pharma, right? Pharmacokinetics. Talking about medications. Okay, so we can pick apart this word. Kinetics meaning the action of a drug, absorption, distribution, metabolism, and yes, thank you, kidneys, excretion, and liver too as well. Um, pharma, um, Pharmacodynamics, that is the mechanism of the drug's action. How does it work? Therapeutic ranges or windows, receptor interactions, we'll talk about that. Okay, so let's dive into chapter 1. You have some key terms here. And if we are in an accelerated program, and with that comes, well, as you guys have seen, it has an interesting workload, right? Uh, Myself, I am from an accelerated program, so allow me to share some of the things that helped me in my journey. Um, Utilizing outlining your chapters. Okay, so I would look to start outlining it. Handwriting is going to be essential because there is supporting research that suggests writing something helps for memory recall. Okay, because we don't just want to teach you memorization, but we want to enhance your critical thinking skills so you can apply what you're learning to scenarios. And that's exactly what NCLEX is going to test you on too. And you'll be tested every day in your career with it. So we teach it early on. Okay. So fresh set. Let's talk about it. So key terms, review your key terms. If there's any one of your key terms, let's say I'm looking at on page 3, your key terms talks about anaphylactic shock. Okay. If you're confident on what that means, you skip it, right? But if you're like, I have an idea what it means, I'm not really confident, that would be to where you would make some notes. And I do highly recommend handwriting them, drawing pictures, using colors. And I'm not talking about drawing a giant Picasso canvas. No, just a small icon for you next to your word. It's completely optional. But if we're more visual learners, where we have to see things to understand it, that may be more beneficial for you have to understand you're probably learning your learning style right now. Okay. So if I didn't know anaphylactic shock, I would say, okay, I'm going to note that one. I don't really know what that is. Angioedema. Maybe you're like, oh no, I already know what that is. That's where my face and my mouth and my tongue is going to swell. It's going to occlude or block my airway. That is life-threatening medical emergency, right? You got it. Okay. And typically it's a side effect of a specific antihypertensive and ACE inhibitor called the lisinopril. We'll digress on that just a second. You go down to the next one, bioavailability. That's where you're scratching your head. You said, I don't really understand that. That's muddy for me. That's a muddy area, also known as a laundry list item. Okay. But let's get into it. You have my suggestion on key terms, right? We also look at our learning objective. We want to know what pharmacology is and just review these objectives. That's the goal of the chapter. So if we can speak to all the objectives in the chapter, we have an excellent understanding. Okay, and then of course I will send you more supplemental information to tailor you're learning just a bit. Okay. So we want to understand exactly that medications are derived from natural resources, plant, animal, synthetic, chemical compounds, right? Um, that we or pharmacy will chemically engineer to have a target action, to have a target area or zone, how bioavailable it is, how it distributes to the body, what is the target organ that it goes to. We're going to talk about all those things. Okay. Um, let's get into, if you're following along in your book with me, you want to look at the bold print. They're typically colored. Like, for example, if I'm on page 4, I'm looking at drug name, that's bold print. If I'm writing my note, I would outline the chapter and write that down. And then I want to read the first, let's say, paragraph. Okay, maybe 2. If you don't understand what this area of the book is trying to discuss within reading the first 4 to 5 sentences, then you continue to read until the next bold print. For example, page 5, drug classes and categories. This is a way to start outlining your chapters. Okay, if that speaks to you, it's certainly an option. It doesn't have to be the only option. Okay. So we need to make sure we understand about drug names. Okay. So your drug name is going to have trade name or proprietary, meaning who is going to benefit and make money from this? Is a trademarked item. It's kind of like having a copyright. You know, when you go to, let's say, CVS and you're like, oh, I need to get some Motrin. Well, Motrin is a name that makes a lot of money for the company who owns it. I don't remember who owns it. Probably Procter and Gamble. And besides the point, Motrin is a trade name or a proprietary name. That's how it is sold. But when you flip it over and look at the ingredient, what is it? The active ingredient is ibuprofen. Okay, now ibuprofen can be sold as Motrin, can be sold as ibuprofen, right? Now they're selling the dual pills. It's compounded with Tylenol and Motrin, but what does that really translate to? Tylenol, um, prostaglandin 1 inhibitor, also known as Tylenol, which is the trade name for acetaminophen. Okay, acetaminophen is the generic name. NCLEX will test you on generic names only, not proprietary or trade names. Okay, so we need to understand that these are how these are classified, generic name. So let me give you an example. Claritin, right? We've seen the commercial for it. We've walked in the store and seen it. Typically, you'll notice that the brand name, the proprietary name, is more expensive than the generic, but it is essentially the same chemical properties to be labeled as that drug. It's also known as loratadine or loratadine, tomato. But loratadine is the generic name for Claritin. Okay. It is the name given to the drug by the FDA has something to do with it, but it is a name that is given to the drug before it is given a trade name by the manufacturers. Okay. We do not capitalize generic names. We do capitalize trade names. Okay. And the FDA basically, yes, it does give them that name. Okay. Now, let's shift gears. Let's talk about the drug classes and categories. Okay. Now, besides understanding that there is different companies and insurances that classify drugs in a tier system for costs and purposes, or for drug enforcement, like the DEA, it defines drugs according to the legality of the drugs and basically the danger that comes with some of those certain drugs. Okay. All of that being said, it is imperative in nursing school to understand that drugs are learned in classes. Okay. Drug class or category. We will teach you, and those are interchangeable terms. We're going to teach you how to understand the drugs in the category. Okay. There is also a difference between prescription drugs versus over-the-counter or OTC, also known as non-prescription drugs. Okay. So if the drugs are safe for the general public to make their own decision on what drugs they want. For example, any one of us can walk into CVS or HEB and say, my head hurts. I think I'm gonna take a Tylenol. You just made that decision. You didn't need an MD or a mid-level nurse practitioner or any other provider to order that drug for you and write you a prescription and send it electronically to the pharmacy. No, you walked in, it's on the shelf, you made your decision. Okay, this is what I want. And the idea is that you follow the directions from the manufacturer on the back of the bottle. That's what we teach our clients as well. Okay. So the difference between over-the-counter, OTC, or non-prescription drugs is that prescription drugs you're not going to find over the counter. They're going to need a provider to order them. Okay. And then those go to the pharmacy. They could be harmful unless they're supervised by a licensed healthcare provider. And that's the goal, okay? It needs medical supervision. Like, for example, we cannot go to HEB and say, today I feel like taking that the weight loss injection. I think I want to have Manjaro. Let me go and see if they have it on the shelf. Absolutely not. Okay, they're not. Many reasons why that drug has to be monitored. Lab values need to be assessed. A multitude of items have to be assessed. I am just keeping it simple right now and talking about difference between prescription and non-prescription. We cannot walk into CVS, Walgreens, Publix, HEB, Albertsons, Kroger, Trader Joe's, wherever we're shopping and say, I'd like to pick up some morphine today. It'd be problematic. Okay. Right. For many reasons, that drug requires levels, medication management and monitoring. Okay. So definitely need to understand with that. And also, we're worried about prescription drugs having reactions. Do the levels become toxic, right? Because for example, there's notifications and directions on the back of a non-prescription bottle, but a prescription drug will require a higher level of supervision for patients to understand. Sorry. Oh, it's going. Okay. Thanks, Cindy. Thank you. Okay. So I'm still in chapter 1. So the next thing we're going to talk about is controlled substances. Those are carefully monitored. I had mentioned morphine, right? That is carefully monitored. The DEA will be involved in that one. There is certain requirements that must be met. Will the medication cause the body to become physically dependent on it? Right? Will it become habitual? Does it have withdrawal side effects? For example, what if for the last 10 years you were used to drinking 4 cups of coffee per day? And then all of a sudden, after that 10 years of 4 cups of coffee per day, you said, nope, I'm done with the caffeine. Done. No more coffee. Right? That's also a terrible thing, no coffee. But anyway, all joking aside, you're going to have withdrawal symptoms. You're going to have headache. You might be jittery. A cascade of withdrawal effects. The same thing happens when somebody's taking a high alert med, a controlled substance that has the risk or potential for abuse, either physically or psychologically. Okay. Is there cravings for it? Is there compulsions? There is something in the brain that says, I need this drug and I need it now, or else the mind will continue to have this desire for repeated administration of drug. Okay, so consider those aspects there. Okay. Drug development. Okay, this is quite a tedious process. They quote about 7 to 12 years before FDA approves them. Sometimes there's pre-approval phases. I will not talk about emergency approvals right now. But anywho, there are phases to drug approval. There is an entire process, okay, during the FDA, we're going to have clinical trials. Okay. There is going to be preclinical trials for efficacy and toxicity. Then they're going to have case studies. Okay. Um, the drugs has to be cleared for human testing, for clinical studies, for larger scale clinical studies. And then there is a further phase. They're going to assess throughout the way, how's the side effects? How is the therapeutic effect? Is it therapeutic? Okay. Um, so those are integral to understand. For example, a reason for a drug to enter phase 2 would be to test the potential drugs on clients with a disease, maybe like a new antihypertensive medicine. Is it going to work on somebody who has maybe stage 2 hypertension, okay, or somebody who's in hypertensive crisis? More information to come on that, but I'm typically talking about systolic blood pressure of 140 and diastolic of over 100. Okay, that danger area, for lack of better words here. Now, Special Food and Drug Administration Program. The FDA has special programs to meet different needs. Okay, for example, Orphan Drug Program. Those are for rare conditions, to treat rare diseases, and entices the manufacturers to utilize funding resources to research and develop these drugs. Okay. Then they have 7 years of exclusive marketing rights, but we won't go there. Okay. Accelerated program for urgent need. That's something that we've seen during COVID, where they sped up this process for emergency management. I'm going to kind of skip a little bit here. I really want to talk about the pharmacokinetic phase, okay, and the pharmaceutic phase. How does the drugs work within the body? And we need to think about how a drug comes into the body, route of administration, okay? Is it oral? Is it IV? Is it transdermal? Okay. Is it suppository? What is it? Is it liquid? Again, oral, sublingual, buccal, nasal, intranasal, okay, to name a few. So we want to think about that. But while we're thinking about that, the pharmaceutic phase is how the drug is dissolved. It is a soluble liquid that must be absorbed in the body. Okay, like injection, parenteral drugs. Think about an IV drug going into a peripheral IV in the arm. That drug is already dissolved. The solute is dissolved in the liquid, and then it is put right directly into the bloodstream through the vein. Now think about it. The ultimate goal of any method of administration, I forgot to mention IM and sub-Q, is to get to the bloodstream. But it is the time in getting to the bloodstream that is different, okay? How it goes from the form that it's in, and how does it get to the bloodstream? Think about it in that essence, okay? For example, you ever looked at a baby aspirin? I think Bayer makes baby aspirin. They're yellow, and it has this like coating on the outside, right? If we really were to do a deep dive into it, that is called an enteric coating. So we ingest it orally, right? It goes down, we swallow it, it goes down the esophagus, down into the stomach, and the goal is to be absorbed, okay? But rapidly, slowly, it depends on the coating. How fast does the drug dissolve? Okay, how fast does the drug dissolve? Enteric coating is meant so it is dissolved and absorbed correctly without causing any tissue problems inside of the stomach. We want to prevent an ulcer. It is coated for the stomach, okay? We're going to talk about that. Pharmacokinetic refers to the transportation of activity in the drug in the body after the administration. So think about absorption, right? Think about the first pass effect. Distribution, how the proteins are binding, Metabolism is going to be your peak onset and duration, and the excretion is going to be the half-life. How much time does it take for your kidneys to excrete the drug? Okay. Does it have a short half-life? Like, do you pee it out within 2 hours? Or does it have a longer half-life where it's going to take like 8 hours for excretion? Okay. Example, valsartan, an antihypertensive blood pressure medicine, and ARB, angiotensin receptor blocker, ARB, okay? That drug is going to have a longer half-life because it is meant to be and like has an all-day therapeutic effect, supposedly, okay? According to research here. So that's some of the examples. Absorption, how is the drug made available for the body? Okay, is it a pill? Is it a tablet? Basically, if it's in a tablet form, if it's oral, it's going to go into the stomach. The stomach is going to break it down and get it into the body fluids, where maybe we're going to have some transportation. Okay, thank you to active transport. That's going to be energy to move the drug from a low concentration to a high concentration. Where does it need to go? Or does it use maybe passive transport, where no cellular energy is used, okay, as the drug moves from an area of high concentration to low. There's several factors though, okay? For example, IV route is essentially ideal because it goes directly to the bloodstream, but also it offers 100% bioavailability. It's not broken down in the stomach. It doesn't have to rely on other cells and first pass effect as far as absorption goes. It doesn't have to bind to any proteins to help get it distributed to the blood. It is put right into the vein, which is vascular circulation. Okay? Because that's how it's going to get to its target organs. That's going to be the goal. What is the first pass effect? When the drug is absorbed by the small intestines, it passes into the liver. Before going to the rest of the body, the liver is going to be like, hold on, wait a minute, let me see what's going on here. Okay, let me look at this medicine. Let me see where you need to go, because they are the gatekeeper of that drug for the first pass effect. Okay. It'll filter out and metabolize a significant amount of the drug before going into the body. So if I were to take a Tylenol orally, it's going to go into the stomach, it's going to go to the liver and have the first pass effect. So some of it is going to be out just due to metabolism from the liver. Thank you, liver, right? However, if you were to give me Tylenol intravenously, yes, there is such thing as Tylenol intravenously. It is 100% bioavailable right to my blood. Okay, that way it gets distributed to the body system that depends on it. And there's some things to consider, like blood flow, solubility. Oh, solubility. Let me explain that. You ever taken any B vitamins, multivitamin? Okay, what happens to the urine? It looks like super bright neon yellow. Normal, okay? Uh, because it is water soluble. We are 60 to 70% water, right? Our kidneys are filtering the fluids, the humor, the water all day, and the other nutrients, toxins within it, okay? So it can maintain pH, acid-base balance, and overall fluid balance in the body with the help of other organs too and other chemical modulators. But let's just keep it simple for right now, right? So with that said, that's why you may see some presentation in the urine when it's a water-soluble drug, okay? It's interesting how that works. We need to make sure that we understand that. We advise our patients on that. There's water-soluble, fat-soluble drugs, so it's best absorbed with maybe some fatty lipids, lipid emulsion, etc. More to come on that. But the ultimate goal here is to understand these phases within drug activity within the body, okay? Drugs can also bind to protein. There's lipid-soluble drugs that help easily pass through the cell membrane, whereas water-soluble drugs don't. Okay. Protein binding when drug travels through the blood comes in contact with proteins such as albumin, plasma protein that helps also with fluid balance in the body, works with the liver, but we'll talk more about that later. Okay. Let's keep going on chapter 1. Metabolism, biotransformation. This is how the liver breaks down the drug that's coming into it. Okay. Excretion. There's excretion, removal of the drugs by the kidney or the GI tract. We're going to excrete it out, right? Urine or fecal matter, we will excrete it. Excuse me, half-life is the time it takes the body to eliminate 50% of a drug, whether that would be through fecal route, excretion through the kidney, intestine, or through the kidneys with urination. Okay, that's the half-life, time for the body. Knowledge of this is super important, okay? Because if it's a short half-life, maybe you need to give the drug more frequently. If it's a longer half-life, you may want to be extremely cautious with multiple administrations of this drug. Okay. There's also considerations on the difficulty in excreting the drug. I won't talk about that just yet. We're not there yet. Now, peak action and duration, that is the drug. Onset, peak, and duration is the action of the drug. Okay. The onset is the time between when you give it and the end its therapeutic effect. Okay. So regular insulin is going to be very quick, rapid or short acting. Okay. It's going to happen very fast, less than 10 minutes. Okay. Right now, we're going to talk about that. Peak is when the absorption rate equals the elimination rate. Okay. Peak, when is it at its highest therapeutic range, basically? Okay. Equal rise, equal fall, if you will. That's how I remember it. It's like a peak, like a mountain. Equally rise, equally fall, meaning it is at the pinnacle of working. Yep, it's doing it fabulous right now at the peak. Okay. Duration, well, the length of time the drug will actually produce that therapeutic effect. Okay. This is integral for understanding schedule of drugs. Also proper blood levels. Okay, that is integral. Pharmacodynamics. This is how the blood works once it's in the body. Primary effect. That's the desired effect on this desired organ. It's working. Secondary are the other effects that are desirable and or undesirable by the drug. Okay. For example, maybe you go to the store because you just took a cruise or you're going on a cruise. No, you're on a cruise. Picture this. You're on a cruise. Okay. You went to the store before you got on the ship and you bought Dramamine, okay, to help you with the seasickness that you suffer from because you get nauseous, right? Now, take it as indicated on the box. It helps with the nausea, right? About 45 minutes into it, you're like, ooh, not nauseous anymore. But now I'm sleepy. And why is my mouth dry? It's like sandpaper. Can't even talk. Totally dry. You're drinking water. Nothing satisfies your thirst. Well, you're not seasick anymore. You're not nauseated anymore, but you got a dry mouth and you're tired. You're sleepy. Side effects. Now, it could be opinionated on whether that's desirable or undesirable, but it depends on the circumstance and situation. Obviously, having a dry mouth is undesirable, okay? And being sleepy when you're not supposed to be, like on a cruise trying to have fun with your family, that's not desirable either. So we consider that. Okay. Let's see here. Alternative drug use, pregnancy, lactation. Oh, no, I'm not there yet. Study people's response to medications. Drug reactions. Okay. Um, maybe that's an allergic reaction. Maybe it is drug idiosyncrasy, drug intolerance, or a cumulative drug effect or toxic drug effects. Okay. Um, Polypharmacy comes to mind for seniors taking multiple drugs with some of the same side effects. Okay. We want to be careful with drug reactions because it could turn into an allergic reaction. Okay. Drug tolerance. You've been taking Tylenol for the last 5, 10 years, and you're like, no, you know what? It doesn't work anymore. Pretty tolerant of the drug. Now you went from taking one 350 milligram Tylenol for the last 10 years, and now you're like, well, I better switch to 1,000 milligrams because the 350 just not working anymore. Okay. Toxic reactions, cumulative drug effect. Well, let's go back to that Dramamine I was talking about. You took the Dramamine for the seasickness, right? Uh, but now you're like, ooh, do I really want to go take my melatonin to help me sleep? That's also over the counter. But if you're already sleepy, lethargic, and you're going to go take a melatonin, that might have a cumulative effect. You might be a little bit uptunded after that, or really, really sleepy. Okay. Um, some drug reactions can happen pretty fast, in minutes. And the idea is that science has taught us that, hey, every time you're exposed to an allergen, the reaction is going to be worse. So you want to notate any allergies because the more that the person is exposed to the allergen, they're going to have an allergic reaction. Hives, itching. Hives is also known as urticaria. Maybe they have difficulty breathing, wheezing, cyanosis, change of LOC, swelling of the eyes, lips, or tongue. Those are problematic. We are worried about the ABCs, airway and breathing and circulation. Okay. And that can turn into anaphylactic shock, life-threatening emergency, a serious allergic reaction that occurs shortly after drug administration. Very scary. Okay. Typically, this is going to look like someone whose blood pressure is crashing, going down. They're going to need some IV fluids and vasopressors to increase the pressure. Okay. So if the pressure is pressing, um, it's going to increase the blood pressure. But more to come. We're still learning some of the basics here. Okay. Um, and some symptoms of anaphylactic shock. If you look at table 1.2 on page 13 of your book, you're going to see respiratory, cardiovascular, integumentary, and GI. Those are your typical indicators, especially respiratory, airway breathing, circulation, airway breathing, then circulation. Okay, cardiovascular. Yeah, they're going to have difficulty breathing, coughing, wheezing. That worsens. Forgive me. Okay. Angioedema is another type of allergic reaction. Okay. What's happening is that the eyes, the face, the eyelids, the lip, mouth, throat, they're all getting swollen, inflamed, if you will. Okay. Drug idiosyncrasy is a term used to describe an atypical reaction to a drug. Okay. For example, somebody gets an injection of, let's say, morphine. Pardon me just a second. Okay, so then an allergic reaction is a hypersensitive response because of the immune system. That allergy to the drug usually begins to occur as soon as the administration happens, which becomes problematic when the body responds to a drug as an antigen. It'll create antibodies, okay, a protein substance that protects against antigens. Remember, common allergic reactions occur when the individual's immune system responds aggressively to the antigen. This is the person who's going to say, oh my God, my throat is itchy. Now my tongue is swelling. My eyes are looking swollen. Oh my God, my eyes are red. Look at that. This is where each time they're exposed to that allergen, it worsens, that becomes problematic. They're going to need a hospitalization. Okay. More than likely your EMS services. Okay. Now, cumulative drug, we talked about toxic reactions, toxic levels that build up when the blood is administered, when the drug is administered in doses that exceeds the normal level, like digoxin, digitalis. That is going to need a therapeutic range, a drug level to be maintained. You would want to draw that before administering it. Like as in the IV drug vancomycin, we would want to draw a peak and trough level to see what the blood level looks like before we potentially send the client or the patient into a further reaction. We need to make sure the drug's balanced within the blood to avoid a toxic reaction. Okay, because some of these can cause permanent damage, such as streptomycin and the risk of permanent hearing loss because of the effect on cranial nerve number 8. Okay, some of these toxicity items can be reversed, others cannot. For example, some people, when they take too much of an opioid, we're going to leave out the rationale as to why, but if they have to have an infusion of Narcan, right? Naloxone, that's going to counteract the drug's effect. Okay, it's going to take away that drug's effect. Okay, so we can think about it in that essence. We need to monitor their blood. And as you go through the program and teachings, you'll learn which ones work with each other, which levels work with which drug, or which ones match which drug. Okay, we want to make sure that we understand ways to minimize risks involved with drug reactions. Okay. Drug to drug interactions is something we should be monitoring and checking and understand, like drug and food interactions or drug to drug interactions. Okay. You would not want to have your client or patient take an antihypertensive and then all of a sudden take a Tums with it. Okay. Because what it's going to do is going to block the effect, or eating grapefruit with the blood pressure medicine. That's going to be problematic. An antacid, right? Is where I was going with that. Some of these, for over-the-counter medicines, the directions are on the bottle. For a prescription, that's where your nursing judgment comes in. That's where you understand, hey, this is what I learned. This is what my education has taught me. This is how to be a safe nurse, is through understanding the general principles of pharmacology. So that's why I'm spending a lot of time right now in chapter 1. Okay. When one drug interacts or interferes with the action of another drug, that's going to be your drug to drug interaction. Okay. Additive drug interaction is when two drugs equal the sum of each drug given alone. Okay. For example, taking heparin with alcohol is going to increase the risk for bleeding. Okay. Drug synergism, okay, or a synergistic effect, is when drugs interact with each other that produces an effect greater than the sum. So, for example, when a person takes a hypnotic drug and alcohol, when alcohol is taken shortly before or after the hypnotic, the action of the hypnotic increases. Okay. Yeah, that's like the person that's taking maybe a Benadryl, okay? And then they drink alcohol. That's a synergistic effect. First of all, that's a recipe for a disaster. But you can see where I'm going with it. Alcohol slows down the central nervous system, and your Benadryl will have some of the similar effects, but together it will have a synergistic effect or a synergistic drug reaction. So you want to avoid that. I highly discourage, well, let me say it differently. I wouldn't recommend taking a Benadryl and a melatonin. That's gonna have a synergistic effect with probably a less than ideal outcome. Okay. Antagonists. Antagonists mean one drug interferes with another. Okay. For example, heparin is an anticoagulant or a blood thinner. And its antidote, how do you treat it when someone's had too much of it or having a reaction? Like heparin-induced thrombocytopenia, right? Where their platelets suddenly decrease tremendously under 50. That's a problem because normal's 150 to 450, right? So somebody who is in heparin-induced thrombocytopenia, you would anticipate the drug to be used as protamine sulfate, which is the antidote for heparin. Okay, so understand that that is an antagonist effect. It's going to say, hold on, wait a minute. It means that it'll neutralize the effect. Okay, it's going to stop it. Okay. Drug to food interaction. Okay. Most drugs should be taken on an empty stomach to achieve the optimal effect or absorption. Okay. Except for drugs that we need to worry about and we want to minimize gastric irritation if we're utilizing an oral route of administration. Okay. So we want to consider that when we're thinking about pharmacology, when we're preparing to talk to our patients or family or even ourselves and seeking out information on it. Okay. Other drugs combined with food may be problematic because components of food may also prevent the med from working. Okay. There are certain factors that influence a drug response, like age, weight. Tell you one thing for pediatrics, you better have a height, an age, and a weight. Okay, because of the way the drugs are metabolized by the liver may produce more of an intense effect for longer periods. Okay. The drug safety is a little bit different regarding pediatric and geriatric populations. Okay. For example, for children, they typically require smaller doses because of their immature organ function. Their vital signs are also different than an adult, right? You're not going to see adult-like vital signs until at least adolescence or the age of 12, okay? So children, right? So children, infants, newborns, etc. The age decline will affect the drug. Infants and children are going to require smaller doses than adults, okay? And we worry about immature organs, but which ones? The liver and the kidneys. They're still developing. Remember, they are still developing, okay? Drugs metabolized by the liver is the same as adult, but it may be because it may have a longer intense effect for a longer period of time, okay? Now, on the contrary, elderly clients, geriatric clients may require smaller doses as well because maybe they may have kidney impairment, renal impairments, okay? We would caution CNS depressants within the geriatric patients because of the way the central nervous system is integrated and how absorption, distribution, metabolism, and excretion happen because of the alteration in the physiologic changes that occur with aging, right? The nephrons in the kidney do not function as effectively as they do younger than 65 versus older than 65. Okay, that's some of the key numbers there. Or if there's any secondary issues like a renal disorder, panel dehydration, acute kidney injury, chronic kidney injury, etc. And then I mentioned earlier, polypharmacy is taking numerous drugs that have the potential to react with each other become problematic. Okay. Weight. A drug dose may sometimes be increased or decreased due to the client's weight. Um, factors, there is different factors that alter drug responses. On page 15, you'll see a table in here, and you can review that as you need to. Maybe you're quite comfortable with chapter 1. You're like, no, I'm all right with this. Then that's okay too. This is only to tailor your studies and get you a good understanding of some of what you see here. Okay. Um, There's even some suggestion within the book that gender has an influence on the action of drugs. Typically, women require smaller doses of drugs, and it's because of the body fat to water ratio in men. Well, in women versus men. Okay. Disease. Is there any existing disease in the body? Right? Is there liver cirrhosis? Are the kidneys impaired? Is the liver impaired? Those are some of the considerations to think about. Okay, because if our kidneys are impaired, are we going to be able to excrete the drug properly? Mm-mm. If the liver is impaired, is the first pass effect going to happen effectively? Mm-mm. The route of administration is something to consider as well. We already talked about this. Herbal medicine. We must always discuss that with our doctor. We would always caution taking St. John's wort with antidepressive medicines. And this you can read more as you go through your courses. You'll notice that some of your, if you're looking in your drug guide, if you're looking in your med search book, it'll have excerpts about the different herbal considerations with that. Okay, so now complementary and alternative medicine. I'm not going to spend quite a bit of time here, but let me give you an example. Now, a reproductive medication or a hormone example would be testosterone. Okay, can be synthetic. However, there is alternative or complementary medication to go with it. Maybe it's an element from the periodic table called boron. Boron is an alternative medication to help increase the production of testosterone within the body as a complementary medication. So therefore, somebody who would anticipate testosterone replacement as a hormone therapy, they may, if they go to alternative or oh my goodness, complementary medication, they may be prescribed boron, okay, the element from the periodic table as well. Maybe even DHEA, right? Not just for babies. So that is an example of somebody, a male typically, who has a low testosterone. Maybe they don't want the synthetic testosterone. Maybe they want to produce it in their body naturally. That would be complementary medicine. So those are two supplements that somebody could be prescribed, and the dosage would be from the provider on what to take to help the body produce naturally. Okay. Now, Dietary Supplement Health Education Act. This is where you often read on the back of the bottles that this has not been approved by the Federal Drug Administration. Herbs are not sold and promoted in the United States as drugs. Therefore, they don't have to meet the same standards of drugs as over-the-counter medications. Okay. So interesting how that works. Each country has works that a little bit differently. But let's continue. So we still need to educate patients on utilizing herbs or dietary supplements. Okay. Because they're available everywhere: supermarkets, pharmacies, health food stores, specialty herb stores, and of course, you can order just about anything on Amazon. So now, with that said, it's integral to understand that. Are they taking blood thinners and then and then they're trying to take fish oil supplements, which also could have thinning properties? Are they taking an antidepressive medicine, but now they're taking St. John's wort? Or maybe they're a female and somebody told them to take saw palmetto. That may have a causative effect on a female secondary sex characteristics and produce more male-like secondary sex characteristics. So you want to be mindful, okay? Um, so again, just because they're marketed as herbal doesn't necessarily mean they're safe because they're natural, okay? If you have health problems that maybe there may be an increase in danger when taking some of these herbal medicines. We would always recommend our future patients, ourselves. I highly recommend, even if you are interested in herbal medications or complementary and alternative medication therapies, that you seek a naturalist or an alternative medicine provider to guide you on your naturalist journey. Nothing wrong with that. Okay, absolutely nothing wrong with that. Okay. Let's see. Sit down, we went over that. Okay, so that's going to conclude my review of chapter 1. Now I'm just going to highlight, I'm going to continue to highlight certain things. I may not be able to finish everything on a video. 7 weeks of class would probably take me a good 60 hours to provide to you guys. So that might be irrational, but I can supplement, right? So I feel that having a foundation and learning the teachings from chapter 1 is going to be integral to understanding pharmacology. Okay. Now, some things that we want to know, we have definitely need to know key terms in chapter 2, the administration of drugs. All of these key terms are integral to understand, both for the program, but even for your final. Okay. If you're comfortable with these key terms, you can probably skip through chapter 2. Okay. You need to know the five plus 1 right, which is 6 rights of medication administration. Don't take that very lightly, because there's over 10 or more. They're evolving every day, the rights of medication administration. For your test, it is the 5 plus 1. The right client, the right drug, the right dose, the right route, the right time, the right indication, the right documentation. That's a little more than 6 rights, but anywho, I would definitely read through the rights of drug administration. It's something that we are called to do, we are mandated to do, and we should not cut any corners in there. Chapter 2 covers the routes of drug administration and factors affecting bioavailability. It basically is highlighting the importance of avoiding first pass metabolism. Okay. We want to understand about preventing medication errors. Okay. You need to be able to look at and prepare a drug, validate the order. If you have a question on the order, hard stop. Don't answer your cell phone during MedPass. I highly recommend don't answering any type of anything unless there is a code during MedPass, and even that's questionable. Okay. But if you have a code, it should be taken care of. But for education, which is what this video is about, need to definitely understand each right of medication administration and the route of administration. Okay. Preventing med errors. Most nurses, it's extremely sad. Most of us have made a med error. Okay. When med errors occur, report it immediately. Check your patient, and one more time for the people in the back, check your patient. Okay. And then let your doctor know, let your charge nurse know, and cooperate with leadership's guidance. Okay. Need to make sure that when you're preparing a medication, you're doing the 3 checks. Okay. You're checking the medicine when you're pulling it, you're checking it against the order, and you are definitely checking it one more time before you give it to that patient. You need to understand the types of orders that you're working with. Okay. standing orders, single order, a PRN, or a stat order. A stat order is a right now, immediately as soon as possible. It's not after you visit Mr. Smith and you talk to Mr. John and then, oh, let me go visit Nurse Alexis. No, 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 no. It is a stop and treat now. Okay. PRN is when you need it. You got some parameters in there, right? Maybe you got parameters for a PRN antihypertensive. You might need that, okay, if they tend to spike their numbers here and there, right? A single order is a one time. You got a one-time order for, I'm not sure, but maybe a Valium, okay, at IM at 10 a.m. Example, okay? You got a one-time order for Haldol for your patient who was trying to escape and they were halfway into the elevator kicking and screaming at the guards because someone called a code gray because he was trying to escape with an IV in his arm. Not that that ever happened to anybody, okay? But that's a one-time order for Haldol. That's not going to be a repeating dose or a reoccurring dose on the MAR. Nope. Or there maybe is a standing order. An order that the provider writes under specific conditions in the absence of an attending or a primary. So you're going to see standing orders, for example, somebody coming back from surgery. You're going to see protocols being in place, like a K-mag protocol, where they're going to replace the potassium and the magnesium due to the loss that occurs with surgery. Okay. Or you're going to have a standing order for when they come back from surgery because they're going to need a full order set of maybe fluids. They're going to need LR. They're going to need post-op vitals. It's going to delineate everything that they need for post-op considerations. So I was talking about, I apologize, preventing matter. Never crush tablets or open capsules without checking with the pharmacist first or your doctor. I don't forget where I was at. Oh, we're talking about orders. Okay. All right. So now national patient safety goals, drug unit dose. A unit dose is a method in which drug orders are filled and medications dispensed to satisfy each client's medication orders for at least 24 hours. Okay. The pharmacist dispenses each dose in a unit in a package that is typically labeled by the manufacturer and contains one medication. So those are a lot better for tracking and understanding how to properly open and distribute, open and administer medications. Okay. Now I would review table 2.1 on page 25. Excuse me, as far as do not use list. Don't want you to get confused on there. Let's see. So if you're giving drugs in an oral route, right, there are some considerations to understand. Can the patient swallow, right? Can they actually physically swallow it? And they should be in an upright position. And you wouldn't give oral medications to a patient laying down, or if they're in a prone position. Do they need water? Do they take each pill one by one? Do they take them all at the same time? Consider clients with any physical disabilities that they may not have the ability to hold or grasp the water or the medication, or it's risky. They got Parkinson's and you're trying to put a drug med cup into their hand. Where's your pills going? They're going everywhere, right? So you may have to assist. Okay. You need to make sure that water is readily available for them when taking it. If you've had the opportunity to observe medication administration, you might have seen these things. Okay. You would tell them to put the medication on the back of the tongue. They may want to tilt the head back and swallow with sips of water. And that helps move the drug down the esophagus to the stomach. Maybe they're a stroke victim where they need some instructions on how to take it. And you will never ever leave leave medication at the bedside. We'll talk about that more, especially when I see you guys in capstone. Okay. When we're talking about enteral, it's medication administration of drugs by the non-oral or enteral route to basically to the GI tract, maybe via a tube, okay, or nasally or directly into the stomach or directly into the small intestine, okay. Responsibilities, your patients, if they're on enteral feeding, should absolutely be upright at least 45 degrees, okay. And you'll have the lab opportunity to work on administering medications via enteral route. I feel like you guys have already done it. Don't quote me right now. I don't have all the information in front of me. But please review the different key terms for administration. Let me see here. I already mentioned not crushing I need to mention never crush an extended release or a time release medication. Can cause an overdose because an extended release or a time release will dissolve over time purposefully. Okay. Tablets, though, that are able to be crushed can be crushed and dissolved before administration because you want to make sure it is powdered properly to avoid occlusion of the feeding tube. You definitely don't want to unclog a feeding tube, okay? But if you may have to, you might have to get the next level involved. Nursing responsibility, standard precaution is always going to be your responsibility, right? And PPE as you need it, okay? We have went over the IM method, the intradermal method, the Z-track method. So hopefully none of this is quite new to you. If you still feel unclear about it, let me know. You know, we can tutor or let your instructor know, or you can revisit chapter 2 in your pharmacology book, or even what you learned from Funds with me the day I was teaching you guys last term. Okay. Let's see. Drugs at home. First of all, we need to teach safety. For VN scope, you will reinforce the safety taught by the registered nurse, okay, in the state of Texas. And we need to assess the home environment. Are there children? Because if there is, we need to safeguard and make sure that the home has a space for medicines, okay? Easily accessible, free of clutter, so we're not jumping over hoops to assess the medication. Needs to be in a cool, dry area without direct sunlight, okay? Do the meds need to be refrigerated? Can the patient identify the meds themselves or the caregiver? Can they open the bottle? What if they have rheumatoid arthritis? What does that mean? Swelling of the joints, joints, fingers, hands, maybe even wrists, and it's very hard to maneuver and flex enough to grip and open the top. So they may need a rubber grip around the medication bottle, and I think there is manufacturing companies who sell, like Bayer Aspirin sells the rubberized grip to open the bottle. Okay, is there sharps that need to be disposed of? Okay. Let's see. What if the patient has to give themselves a sub-Q and IM injection at home, but they don't have the sharps container that we're used to in the healthcare field. Well, you can advise them to use an impervious container, meaning one that's really hard to puncture. Like, well, if they don't have the proper storage container, like the biohazard sharps container, they can use maybe a milk jug with a properly fitting lid, okay, for safe disposal of the needles. I'm going to digress on that one, but that is an option, okay. There's the client. Now, this may be tricky rural for people who live rurally, but sharps disposal programs in the area, maybe pharmacies, police stations, fire stations, or local health care centers can help the client or patient dispose of those sharps properly. Okay. So that's some of the considerations from chapter 2. Chapter 3 is going to discuss making drug dosing safer through strategies like weight-based dosing, monitorable parameters, and system-based safeguards. We may not finish this, but let's talk about it. Okay, again, so learning the principles better can help. Drug doses safer. Now, in your announcement that I sent in Canvas, I go over most of the aspects that you're going to find in chapter 3 regarding making drug doses safer, how to calculate drugs, how to mix insulins, talk about the different conversions, household conversions. I highly encourage you to watch those videos as far as reconstitution. I do have one on metric conversions, household conversions, desired over have, and pounds to kilograms, liters to milliliters. So they're quite rounding even. Those are short, simple videos that I've created at my last LPN program in the state of Florida that definitely resonates with what you're learning here, which will explain chapter 3 entirely and at length, if you will. Okay. So I'm going to skip over chapter 3. Please review. And it also goes over fractions in nursing med math. So you definitely want to check that out. Okay. The nursing process is something that you guys have had since fundamentals. So I'm going to skip over this one for right now, and I will send you some supplemental information on it. Okay. And it'll be all about the nursing process. Again, very short and sweet. Client teaching was chapter 5. We'll skip to 53 and 54. Let's see what we got here. Okay. I think I can summarize these. All right, so what we're going to do, I'm going to pause right here because we're about at the end of the recording for the free Zoom session that I have. I will send you more information on the drugs and classes. Hopefully the goal is to reach all the learning types. I hope this will help. Again, more information to come. Thank you guys, and have a good day.